Good morning, everyone. Thank you for joining us to this very interesting seminar today to explore primary care and mental health care opportunities, research opportunities in Pakistan. My name is Maria Panagioti. I'm senior lecturer at the University of Manchester at the Centre for Primary Care. And my main interests are focused on around mental health care, especially in primary care, patient safety, and quality of patient care. And as part of my research portfolio, I have also worked on mental health projects from a global health perspective, especially with PIL in Pakistan. So I'm really delighted to host this seminar today at the University of Manchester. And we'll have a number of speakers with diverse interests, which is really exciting, which I hope you will enjoy. And we will start the day today with the head of School of Health Sciences, Professor Kay Marshall, who's going to provide an initial introduction. And then we've got several speakers, and towards the end, Professor Nusrat Hussain will close the session. Has Kay joined us?
Yep, I'm here, Maria. Thank you.
Thank you very much, Kay.
So can I first of all say good morning from a rather wet and cold Manchester, but you'd expect it to be wet and cold because it's Manchester, because that's the north of England for you. So a very good morning to you all. It's wonderful to see so many people on the call. So very special welcome to our honoured guests, researchers and colleagues, and a special good evening, I guess, if you're joining us from Pakistan. So I'm Professor Kay Marshall, and I have the great privilege and pleasure of being the head of one of the 9 schools that make up the University of Manchester. I'm proud to be the head of what I and all my colleagues know is the best of these 9 schools, namely the School of Health Sciences, or SHS. The mission of SHS is really quite simple. We work to improve health through our research and our teaching. And these 2 activities are entwined and mutually compatible, as each have got to inform the other as we go forward. And SHS has made and continues to make a very significant contribution to the university in terms of teaching and research excellence. The University of Manchester is rightly proud of its world #1 ranking for impact in tackling the UN's Sustainable Development Goals, or SDGs. And the fact that social responsibility is the 3rd goal of the university is also really important to us. And I mention these 2 things because I think they're both very important for the discussions that are going to go on today. So in SHS, we are contributing to delivering on the SDGs, playing our part in creating a healthier, fairer and greener world through our research, through our collaborations and partnerships. The healthy and fairer are so important to us because we really want to strive to bring better health to everyone, not just the few. We've learned many things over the last, well, it's nearly 2 years since we left our campus, and some of us are on campus now because of the current pandemic. But it's done many things in bringing into sharp focus the obvious inequalities in healthcare and access to healthcare from across the world. The University of Manchester has 5 research beacons, and in SHS we are making, again, a very significant contribution to that research beacon that we call global inequalities. In SHS, we've got world-leading experts in mental health, psychiatrists, psychologists, mental health nurse specialists, specialists in primary care. And we are very keen to explore inequalities, particularly that lack of parity of esteem that still exists between physical health and mental health. Even in the 21st century, this clearly isn't good enough. In order to do something about this, we've got to work across disciplines and use cross-sector partnerships, such as that exemplified by the Global Mental Health and Cultural Psychiatry Research Group, which is led by my colleague, Professor Nusrat Hussain. Thank you for giving it such a long, complex title for me to try and get out after only 2 coffees this morning, Nusrat. In SHS, our multidisciplinary teams recognise that we all benefit by sharing our knowledge and understanding. And this flow, like many things, should be a two-way process, ensuring that partnerships between institutions from lower middle income and high income countries are equitable, with mutual capacity building and health outcomes aligned to the needs of all the partners, as we work towards transforming global health, ensuring all benefit. So the meeting today is very important as we look for opportunities and solutions. Fortunately, we've got many great people on this call. I think we've got over 100 people now. And I do hope by sharing experiences and sharing knowledge that much needed progress is made in these discussions. So thank you for all for coming online and for joining us. Hopefully we'll achieve much in this morning's activities. Thank you.
Thank you very much, Kay. I just wanted to say that we're going to have a series of presentations and we're trying to keep strict in terms of timelines. So 1 minute before each presentation finishes, I'm going to inform speakers, and then if we've got time, we can have 1 or 2 questions before we move to the next presentation. So far, so good. We're actually ahead of schedule for 2 minutes, so that's good news. And I'm really delighted to invite Dr. Zamir Hussain Suhag, who is the director of the PPHI at Pakistan, to give us a presentation around primary care research opportunities.
Thank you, Maria. Thank you very much for the introduction. So I'm just going to start with the overview of Pakistan and Pakistan overall health indicators and the PPHI itself. So So this is just a profile of our country, Pakistan. It is multi-ethnic and multi-linguistic, diverse country, having 4 provinces and 2 territories, and it is bordering with the Afghanistan, India, Iran, and China, and even some countries of Central Asia as well. The population is 207.8 million, and Pakistan is very rich culturally in heritage, natural, and human resources. And we have main source of income is mainly agriculture sector, and our per capita income is $283 to $326. Literacy rate overall is 60%, and there's predominantly male 75% as compared to the females. We are expecting population doubling in next 30 years. And expenditure of on health is 1.2% gross domestic product, and 70 to 80% of health expenditure is mainly on human resources. Next, please. So here I would just want to focus all of the youth that is very concerning for us, that urbanization is increasing, and there is a huge influx from the rural areas to the urban areas. If you look at 1951, it was 17.7%, and right now it's just touching 37%. But there may be multiple reasons, many factors like lack of health facilities, lack of educations, unemployment. So they are coming out of the rural areas to the cities for job seeking, better education for their families and children, and having some employment opportunities. We need to actually divert our resources to improve the rural areas, to decrease this influx to the cities, because it would eventually lead to a lot of adverse effects and overbulging of the big cities, and to put extra pressure on the resources like infrastructure, health, and education. So we need to move, and we need to work more into the rural areas to improve their all areas in terms of health infrastructure, health provision, educations, and develop some industrial areas to provide employment opportunities. Next. So I'm just touching the healthcare system in Pakistan. It is basically, if you look at this chart, it is in public sector, there's federal government managed public health sector, which is mainly military hospitals, cantonments, other research institutes and hospitals. And in provincial level, most of the health department now after 18th amendment is handed over to the provincial governments. Now it is led by Provincial Department of Health, and it is basically 3-tiered health system: primary, secondary, and tertiary care there. And most of in our country, private sectors is basically serving to the most of the people, like large hospitals, private institutes, teaching hospitals, and other philanthropic organizations as well. So at first level health facilities, these are the basic health units and rural health centers. And at secondary level, these are Tehsil headquarters and district headquarters. These are the referral facilities. And beyond that, there is a tertiary care health facilities. These are basically associated or working very closely with the teaching institutes, universities, and medical colleges. Next, please. So at primary healthcare level, that is mainly, you can say it is located in Union Council level and serving the up to 25,000 catchment populations. And our rural health centers are serving up to the 100,000 catchment populations. If you look at the secondary level healthcare facilities, Tehsil headquarters are a first referral facility, which is serving 0.5 to 1 million peoples, where it is having 40 to 60 bed capacity. And they actually provide all basic and comprehensive emergency obstetric and newborn care. District headquarters is located at district level, which serve its bigger population like 1 to 3 million, and it is having all sort of inpatients, promotive, preventive, and curative services. Tertiary, as I mentioned earlier, it is having more specialized inpatient care services, radiology, laboratory, and other special services. Most of the patients has been referred for some chronic and serious problems to the referral facilities. Next. So this is very interesting slide. If you look at this, the population, only 27% population is having access for full health coverage, and rest 2/3 of the population depends upon out-of-pocket payments. It is a huge. So it needs to be addressed somehow in the future. Next, please. Next, please. So I'm just showing the Pakistan health indicators. If you look at here, the overall fertility rate is 4.9% as per PDHS 2017 and 18. So the most concerning thing for me is actually, if you look at the trend, there is a very slow decline from 4.9 to 3.6 in 2017 overall, which is not very good in terms of our efforts, which we need to put more efforts to decrease the fertility rate. But if you look at the rural areas, it is almost the same as it was in 1990. So it's so much variation between urban and rural areas. The overall teenage pregnancy is still again 5.7%. It is variable in urban and rural areas, but if you look at the our province, Balochistan, in Quetta and KPK, it is significantly high as compared to other provinces of Pakistan. The reason maybe which can be explainable, maybe lack of education, poverty, accessibility, and other contributing factors in health education, health awareness, which needs to be done in these areas to at least have a uniform sort of all health indicators, and it needs a lot of work to educate community and the people to, to avoid the teenage pregnancies, to overcome these cultural and other barriers.
I think we've got a connection issue.
It's connection at my.
I think so. If you could repeat what you said in the last 30 seconds. Okay.
Let me check, please. I'm sorry.
We can hear you very well now, so you can just continue. We just missed a small part of a sentence.
Now I can. I can. Is it working?
Yes.
Hello. Are you able to move? No.
Yes, I can hear you. We can hear you very well.
So, you know, if you look at the overall antenatal cares, it is, you know, it is quite encouraging. In 1990, it was just 26%. Now it is almost 86%. But unfortunately, in rural areas, it is still having low antenatal care coverage, especially in Balochistan. You know, it is a 55% only. So if we talk about the number of antenatal cares, which is recommended by WHO, it is 4+ visits, which are still low. We need a lot of educations, community awareness, and community mobilizations and educations to improve the antenatal care services everywhere. If you see, there is quite encouragement results for institution delivery. It is 66%, which is quite good, but having it is reflecting in all our provinces that Balochistan is again having very low institution delivery, 34%. But it is getting better. If over a period of time there is a trend that in 1990 it was just 13%. Now we are 66%. That is showing that health system is improving, it is working well, it is expanding and providing quality of care at public health facilities. And the home deliveries are in a decreasing.
Dr. Suhag, can you hear us?
Next, please. I'm sorry, Maria, there is an issue with internet services. So I'm just sharing this slide. I'm sorry for interruptions because causes of maternal and under 5 mortality. If you look at the first 7 days of neonatal death, mainly it's asphyxia and prematurity, which can be avoided with the by having antenatal care, intrapartum care, and institution delivery. And if you look at the late neonatal death, 7 to 20 years, it's mainly infections, which can be avoided and prevented by providing hygiene, umbilical care, and this can be 70% deaths can be averted because of serious infections. If you look at the postnatal deaths, it's mainly infections, diarrhea, pneumonia, and meningitis, which are vaccine preventable diseases. And it is mainly due to water, wash, hygiene, vaccination, and nutritional improvement and exclusive breastfeeding. So these are the areas which can, those interventions can reduce these mortalities of serious infection, diarrhea, pneumonia, and meningitis. Major causes of maternal deaths, it's hypertension, hemorrhage, and hypertensions, and it can be taken care during antenatal care and even gestational diabetes. Hemorrhage is 30%. 30% of women are dying due to hemorrhage. It's postnatal care and during delivery, which can be prevented by providing institution delivery, skilled healthcare provider deliveries, and by providing postnatal cares, appropriate postnatal cares, which is missing over there. So we can reduce huge burden of maternal mortality as well. Next, please.
Dr. Suhag, you've got another minute left.
Oh, I have so many slides, please. So can you go to quickly, please? I'm sorry, this is an internet issue. Next, please.
Give you another.
So these are the main causes of stillbirth, mainly intrapartum, or 42% are intrapartum deaths, which can be avoided by having skilled or institution delivery, and 40% death can be avoided by having institution deliveries, which is fresh stillbirths. Next, please. Most of the children dying in first 7 days of life, which can be avoided, like birth asphyxia, prematurity, are the leading cause of the death. Next, please. So childhood mortality is very steadily reducing. If you look at the trend, neonatal mortality is from in 1949, now it's 42. So under 5 mortality is decreased 38%, but neonatal mortality is only 7% reduction in last 30 years. So we need to actually improve in this area to reduce the under 5 mortality. Next, please. So this is the vaccination coverage. It is improving, but not up to that scale. Only 65% is overall vaccinations in Pakistan. Punjab province is leading, and Balochistan is significantly impacted by all these factors. We need a lot of work to prevent vaccine preventable diseases, which is an issue actually to prevent mortality and morbidity under 5 children. Next. This is a wasting. Wasting is a high, 7.1% in overall in Pakistan. It's significantly high in Balochistan. If you look at the stunting, stunt is 37.6% in Pakistan, but in Sindh and Balochistan, and FATA and KPK, it is really very high. So we really need to work on this chronic malnutrition, and the organizations are working, and we need to educate people. We address the poverty, and these are the main contributing factors. It is high in those amongst those which are having no educations and having low wealth contacts. So I'll give you quickly PPHS, and PPHS is it's a public-private partnership along this government of Sindh, and we are having 61% of health facilities, primary level healthcare facilities in entire province of Sindh. Next, please. Next. So we work in 24 districts out of 29, and serving 15.6 million catchment population, and we have 315 basic BHU plus, that is 24/7, has been expanded from 6/6 to 24/7, providing MNC services round the clock. We have solarized 645 health facilities because there is a huge electricity failure problem in our rural areas. So we are going to solarize all our health facilities over a period of time to make it functional. We have warehouses. Okay, carry on. Next, please. So we provide all these investigations free of cost to the pregnant women and other of our routine health care services. We are trying to provide more and expand our laboratory services at a larger scales to provide further investigations free of cost to the under marginalized people of this province. Next, please. So this is the, actually just want to show you quickly that the public-private partnership works very well. We have started to work in 2011. Now you see overall 25.5 million people we are serving. It is increasing trend since we are working along with the government and the public-private. All our services have improved a lot. There's improving trend in ANC, PNC, and delivery coverage. So this is a model which is working. I would say this model is having left a significant impact on all our indicators in Pakistan. Next, please. So these are, we are screening and trying to diagnose the tuberculosis and sexually transmitted disease, which were almost negligible prior to this public-private partnership model. Now it is having a very significant. We are screening all women, pregnant women, for HIV and other sexually transmitted infections. Next, please. So my key findings are poverty and illiteracy having huge adverse impact on all kinds of healthcare seeking services, especially MNCH services. There is a low healthcare seeking behavior in rural communities as compared to the urban areas, mainly due to illiteracy, poverty, affordability, lack of availability, accessibility, and non-functionality of public healthcare services in that areas. Children of women with no education and poverty are more likely wasted than those mothers who are educated in highest quintile. Children of women with no education are more likely to be stunted those whose mothers are educated. Stunting is inversely related with the wealth quintile. 57% of children in the lowest quintile are stunted as compared to 22% of children with highest quintile. Child mortality is highest among children whose mothers are no education and extreme poverty. Next slide. Newborn asphyxia and sepsis in prematurity, as mentioned earlier, accounts for over 80% of neonatal deaths. Pneumonia and diarrhea deaths are responsible for over half of the infant and child deaths. The pattern and location of deaths suggests the poor care seeking as well as the quality of care in the health system is an important determinant of newborn child. Over half of all under 5 days occur in newborn period, most of within first few days of life, which I already have shared with you. Child mortality has not reduced significantly over past 30 years. Next, please.
Dr. Sugar, I have to say that we need to.
These are our partners, you know, Aga Khan, UNICEF, WHO, Accelerated Action Plan. We are looking for more partners to enhance our health system, research. Thank you very much.
Thank you. Thank you.
And I'm sorry for these interruptions.
No worries. This is an online workshop, so it is usual. And thank you very much for this interesting presentation. And I have to say that if anyone has any questions for Dr. Zugar, please add them in the chat room, and we can discuss them towards the end. Our next speaker is Professor Atif Rahman, Professor of Child Psychiatry at the University of Liverpool.
Thank you very much. Thank you very much. So I'm Atif Rahman. I started my career in Manchester, actually. So we have a history of strong links with Manchester. Some of my mentors, like the late Richard Harrington and Professor Francis Creed, were from Manchester. And I also work very closely with Professor Nusrat Hussain and Professor Carina Lavelle, who's also here, I believe, in the audience. So Dr. Suhag raised some very interesting issues around maternal morbidity and mortality. And one of the key areas that I am going to talk about is perinatal depression or maternal depression. And the reason maternal depression is so very important and linked to other child development and maternal development indicators is that it's intrinsically linked to underdevelopment of children. You mentioned stunting being a key problem, and perinatal depression has been found to be independently linked to stunting in children and low rates of breastfeeding, etc., low uptake of immunization. So there are a number of indicators that you mentioned in your presentation that are linked to perinatal depression, which is why perinatal depression is so important to address. So I work with a number of colleagues, and this work is a representation of all of our efforts. Next slide, please. I'll give you a little context about, and I'm going to now focus on Pakistan. So a couple of years ago, the then Minister for National Health Services, Zafar Mirza, whom you can see in the center, asked for a meeting of experts to do something about maternal depression because it was increasingly recognized as a significant public health problem. And Pakistan at the time was also in the process of reforming their primary care systems. And the minister wanted us to think about ways in which we could integrate maternal depression with primary health care and the concept of universal health coverage, which is one of the key sustainable development goals. So we met a couple of years ago and we put our heads together. And I'm glad to say, next slide, that this actually led to a very important initiative that was led by no less than the president of the country himself, who initiated a program called the President's Program to Promote Mental Health of Pakistanis, where the focus actually was on maternal and child mental health. And next slide, please. And the reasons why early interventions were selected to be part of this presidential initiative were, number one, there was a very high prevalence of maternal depression in Pakistan. 1 in 4 women will have a mental health problem in the ongoing year. The treatment gap is huge. 90% will not have any access to treatment. And as I mentioned, maternal depression leads to poor health and development in infants. And that's a very big ignored fact. You have to treat the mental health of mothers if you want to improve health indicators of mothers and babies. There's no getting out of that. And so, you know, it's very much their mental health. And the opportunities for prevention. I mean, 65% of adult disorders have their origins in childhood. And if we could address these, then you have a fair chance of dealing with this huge morbidity of mental disorders. Next slide, please. Some of you or most of you will be familiar with the famous Hackman Curve. The earlier you intervene, the better returns you have on your investment. I'll not dwell on this slide. Next slide, please. So many years ago, and this was when I was sort of partly in Manchester and partly in Liverpool, we started work on developing an intervention for maternal depression in Pakistan, an intervention that utilized principles of task sharing, where an evidence-based psychological therapy could be delivered by community health workers or lay therapists. We have since done a number of trials in South Asia demonstrating the effectiveness of this intervention. And I'm delighted to say that the intervention has been adopted by the World Health Organization as their a part of their mental health gap action program. And it's now the intervention for perinatal depression in low and middle income countries. Next slide, please. Delighted also to say that Dr. Nusrat Hussain and his team have used the Thinking Healthy program, integrated it with child development programs such as the Learning Through Play, and have found very favorable results in urban areas as well. Next slide. So what is the Thinking Healthy program? It's based on cognitive behavior therapy principles, simple steps, integrated into community health worker routines, 5 days of training, but a lot of emphasis on on-the-job learning and supervision, and 3 key ingredients of cognitive behavior guided discovery using pictures, behavioral activation, and problem solving. The manual can be downloaded from the WHO website. So I have a minute left. Okay. The other interesting fact is that the price of treating a woman with depression is less than $10. So two cups of coffee, you can treat a woman with perinatal depression. Next slide. There are many benefits to the child. As I mentioned, maternal depression is linked to child development, and the intervention actually improves these outcomes. Next slide. Many countries are now using this. It's been translated into over 7 languages, but manuals been downloaded more than 20,000 times. So please do have a look at the manual. And what is the work that we are doing these days? They're very exciting. Now we are trying to scale up the intervention, and scaling up presents its own challenges. You know, once you do it in an experimental research setting, yeah, you get your results and all that. How do you then train 100,000 health workers? How do you try to integrate it into 5,000 primary care health centers? Now we're increasingly looking at how technology could play a role. Next slide, please. And so we have managed to develop a training program that's fully technologized. So it's a tablet device that any supervisor can take to their community health workers over 3 days, use this automated system to provide training without having had any other training. So it's a standalone training. Sorry?
1 minute left.
1 minute left, okay. And we have demonstrated that this technologized training is as effective as face-to-face training with experts. Next slide, please. And here's the really exciting project that we are currently undertaking. We also found that when you scale up these interventions, their effectiveness drops because of program drift or voltage drop, as the implementation scientists call it. You know, you can't monitor 100,000 health workers as well as you can, 40 or 50 during your research. So we are developing a delivery tool, an app that a lay therapist can use and therefore stick to fidelity and quality controls built into the app. This is an NIHR Right grant that we are currently in the 2nd year of. And if we are able to demonstrate that using this app and a minimal amount of training and supervision, a lay therapist is able to treat a woman with depression, that could be a game changer in this arena of how you make interventions more accessible. So it's exciting times indeed, working in Pakistan in collaboration with the northwest of, universities of Manchester and Liverpool, work very closely together. Unlike our football teams, we don't compete, we collaborate. And so the idea here is that how can we pool our resources to find the best solutions globally? Now I have my last slide, please. Thank you very much.
Great. Thank you very much, Dr. Rahman. Very interesting presentation. I was wondering, because we're late in terms of our schedule, whether we can actually, whether people can put some of their questions in the chat, and then perhaps if we have time, we discuss them towards the end. I would like to invite the next speaker, who is Dr. Min Wei Won from the University of Manchester, who is going to present focus on preempting intervention work.
Thank you, Maria, and thank you very much for inviting me today. It's a pleasure to come here and talk about my work. That's really an accumulation of work I've done over the last 15 years or so in autism, and particularly in very early intervention, also known as preemptive intervention. I do work with Professor Nusrat Hussain, but the work I'm talking about today is primarily with Professor Jonathan Green at Manchester University and Professor Andrew Whitehouse in Perth, Australia. Next slide, please. Okay, so my background is as a developmental psychologist, and actually my work is really more about social and emotional development and early parent-child interactions and the importance of that, and actually touches on a lot of what Professor Atif Rahman in the last talk was talking about. But this particular work is about autism. I'm going to very briefly discuss what is autism in case it's not very familiar to you. Sorry, the slide is slightly out of date, but basically I'm going to introduce early intervention because I realize how little I can fit in 8 minutes. So I won't talk about in the Pakistan cultural context, but I will introduce then the work that we've done on very early intervention, and maybe at the end we might be able to talk very briefly about implications for a Pakistan context. Thank you. Next slide. Okay, so autism spectrum disorders, as you can see from the title, is a range of disorders within kind of autism. It's a neurodevelopmental disorder and involves social and communicative atypicalities and also repetitive restricted behaviors. Okay, it's often seen as a childhood disorder, but the effects can be lifelong, and it's usually diagnosable from 3 years of age, but often is diagnosed much later. And in fact, often in adulthood as awareness has increased in communities. So neurodevelopmental disorder, it is thought to have a large genetic component, but not completely. I focus on social communicative atypicalities, although both sets of symptoms are required for a diagnosis. Social communicative atypicalities have lifelong impacts on the individual. Social communicative impairments or kind of atypicalities are linked with a wide range of developmental outcomes, including academic performance, severity of behavior problems, and the ability to form and maintain relationships, which is very important to quality of life, especially later on in life. Okay, so autism is there's often high comorbidities, like with intellectual disability and with autism. Sorry, did that go forward on its own? Sorry. Yeah. So, there are high comorbidities, but it's not to be confused because, there are high rates of mental health problems. 70% of individuals with autism have mental health problems at some point in their lives, and also intellectual disability is highly comorbid. But there are also individuals with autism spectrum disorders who don't have any of them. So that's not to be confused. Okay. In terms of rates, around 1 in 160 children worldwide are thought to have autism spectrum disorders based on studies, but rates can vary hugely, as you can imagine, depending on reporting and recognition diagnosis. And there's very little work in the Pakistan context, especially early in life, but there are commonalities in terms of the challenges when thinking about diagnosis and early work preemptive interventions for autism, commonalities across lower middle income countries in terms of public awareness and professional understanding, but also cultural differences in developmental expectations and expectations of behaviours of children. So to take one cultural example, it's eye contact between elders and young children is perhaps not as highly expected in some cultures as in Western cultures, and low eye contact is thought of to be an early indicator, is an early indicator of autism, although a whole a range of behaviours has to be looked at. That's just one feature. And also stigma is leads families to conceal possible cases as well. Next slide, please. Okay, so there's no cure for autism. And in fact, if you talk to many adults with autism, they wouldn't want to be cured. So there is a huge, there's high heterogeneity in the population of individuals with autism. However, early interventions do tend to focus on reducing symptom severity, and especially in kind of social and communicative development, and improving functional skills, cognitive ability, and language. For example, speech and language therapy is common as well. So it's about reducing symptom severity, and in particular, thinking from a developmental viewpoint. I'm a developmental psychologist. I'm thinking about how to increase social development, improve social development, enhance that. Okay, most interventions that exist will focus on post-diagnosis and are heavily behavioural, very intensively working directly with the child. Our approach is very different from that. It's working preemptively, that is with the prodrome. So it's early intervention as atypicalities start to form and start to show, and parents perhaps start to notice atypicalities. Just working with parents of infants and toddlers at risk of autism. I should be very clear at this point that we're not suggesting here, and there's no evidence to suggest that parents are responsible for the autism. That's not what we're saying at all. What we're saying is that the developmental research shows that the research shows that autism, sorry, I'm just trying to, it's great having these comments, but I can't see my slides. So it's really that parents provide the framework for social opportunities and social development of infants, and that is in the normative population, typical development as well as atypical development. Next slide, please. Okay, so I'd like to introduce our intervention. It's got a long name, eye basis fit. the full names at the bottom there. It's really a behavioural intervention adapted for autism spectrum disorder. So it was originally parenting intervention. VIP is video feedback intervention to promote positive parenting. So there's a focus on video feedback, also the positive aspect of positive parenting, okay? It's about enrichment of the infant's social interactive environment using parent-mediated program to enhance early social engagement and reciprocity. And reciprocity being that kind of natural, what many of us would count as natural back and forth in communication and interaction between individuals. The theoretical underpinning is that early emerging atypicalities may disrupt early parent-infant interactive dynamics. So to take that example of eye contact, if there's a tendency for the child not to want to engage in eye contact, then some parents may feel that this, they may feel hurt, they may feel that it's disrupted the interaction, they may withdraw from the interaction, they may become more directive and controlling of interaction. So there are many different ways that parents can respond. And so the idea is that early atypicalities may disrupt these natural dynamics, and therefore it's working to repair those dynamics, and the intervention is focused around that. So in fact, my work published in 2012 and 13 with our group has shown that parent-infant interactions are affected in infants at familial risk. We studied infants with an older sibling with autism and compared them with typically developing controls, and found that there were, at 1 year of age, differences in the way that parents interacted with those infants. Next slide, please.
Dr. Wei, please wrap up, because we need to move to the next speaker.
Sorry?
Can you please wrap up, because we have to move to the next speaker. We just
That's great. Okay, do I have 1 minute or?
Yes, 1 more minute.
Okay, great. So so this is very much a non-directive behavioral intervention. So it's not working intensively with the parent or child in that directive way, like in a coaching way, but really it's working with the parent non-directively using video feedback, and it's very infant-centered. Next slide, please. Okay, and so far we have 2 RCTs, a British one first and then an Australian replication with infants, and we found symptom reduction severity that persisted to 36 months of age. So both RCTs, I'm just going to, if you look at the first, I don't know how to get my, the thing up there, but if you look at the first dot on there, that's pre-intervention, the second dot is post-intervention, and then we've got 24 months, then when the child's 24 months old, and then 36 months old when they were diagnosed. So we can see that although there is some change, you see the area under the curve, that there is persistent symptom severity reduction. Next slide, please. And just very briefly summarising the secondary findings, my focus has been on looking at the parent-child interaction, because that's the proximal kind of outcome, the thing that we're trying to target and change in this intervention. And we found improved parental interactions towards the child, either in terms of increased sensitivity of the parent or reduced directiveness. Okay, in terms of the other results, this was less consistent. So you can probably see from the age range, we focus on the 9 to 15 month old age range, so largely pre-verbal, so we're not focused specifically on language. And so it's perhaps to be expected that we didn't see generalizations across that context. Next slide, please. Just very briefly concluding comments. So autism is relatively common, around 1% of the population, I think, and underrecognized, underdiagnosed worldwide. Very early intervention can be enriching for child social communicative environment at a time, which is very important, and Atif Rahman was showing that slide about early preventative intervention having a real impact over a lifetime and can alter trajectories. We've got promising results from that up to 36 months of age, and we can consider cultural considerations. There have been lots of interest in this intervention across. There's been requests from 16 countries recently, as we've published this year the Australian outcomes at 36 months, and it'd be interesting to see whether it's possible to implement in an LMIC context, but bearing in mind that there are cultural considerations around use of video feedback and studying parent-child interactions directly through video. Thank you very much.
Thank you. Thank you very much. Let's move quickly to our next speaker, who is Professor Tracy Mills from Liverpool School of Tropical Medicine.
Hi. Thank you. Thanks, you've rather promoted me. So I'm Tracy Mills. I'm a senior lecturer in the Centre for Childbirth, Women's and Newborn Health at LSTM. So I'm going to talk today about some work that we've been doing around improving bereavement care after stillbirth and neonatal death in low and middle income countries, including Pakistan. And so I'm speaking on behalf of the team at LSTM, and I was previously at the University of Manchester, where I worked with Nusrat, Carina and several other people on the call. So stillbirth and neonatal death are a really huge global public health problem. There's around one stillbirth and neonatal death every 16 seconds globally. So it's a huge burden, and most of it falls on low and middle income countries, so estimated at around 98%, with around 70% burdened on sub-Saharan Africa and South Asia. So of interest, the rates of stillbirth and neonatal death in Pakistan are around 10 times what we'd see in high-income countries. And for Pakistani women in the UK, we know that Asian women have a 60% higher rate of perinatal mortality compared to their white counterparts. So this is a neglected and very tragic situation, because most of these stillbirths and neonatal deaths, as the first speaker alluded, would be preventable with access to high quality antenatal and intrapartum care. And looking at this from a mental health perspective, we know that stillbirth is, or neonatal death is amongst the most traumatic life event for parents. And if you look at the little schematic I'll put up, which came from the Lancet series in 2016, it has wide risks for poor mental, physical health and social outcomes. We know that support that is provided by health workers in the early hours and days after the stillbirth is really important protective factor in preventing poor mental health outcomes. But this globally has been found to be inconsistent, and there is very, very little current understanding of parents' needs or health system responses in low and middle income countries, or actually for minority communities in the UK. Next slide, please. Next slide. So understanding a little bit more about how we might go about improving bereavement care was a significant focus for our NIHR Global Health Research Group on stillbirth prevention and management, which was looking at prevention and management in sub-Saharan Africa. So that was from 2017 to 2021. And in this group, we worked with 6 countries in East and Central Africa, and very importantly, had a very strong link with a midwifery research network. That's the Lugina Africa Midwives Research Network, who were partners in our studies. And a very important focus of this work was understanding the experiences of parents and health workers around the death of a baby. So next slide, please. We conducted some qualitative exploratory work in Africa. So if you just click forward and put all the next bits on, that would be great. Thank you. Just carry on, to the end. So the themes from our qualitative work were that parents were profoundly affected by the experience of the death of the baby. They had very inconsistent experiences with healthcare in the facilities after their baby had died. So they often felt they weren't a priority, and the communication around what had happened was really poor. There was quite a lot of information around the social and cultural context of stillbirth and neonatal death in Africa. So some of the traditional beliefs and understandings that affected parents' adjustment and recovery after stillbirth and neonatal death. And we also interviewed health workers, and they told us about their experiences, which were coloured by the lack of staff and the lack of resources, which meant they couldn't give attention to these parents, lack of training and guidelines. They were very dissatisfied with the care that they were able to provide. and there was significant blame and fear within the health system as a result of increasing amounts of litigation and complaints related to stillbirth and neonatal death that the health workers encountered. Next slide, please. So that work in Africa is continuing. We are developing some interventions both to improve facility care and community support for parents after stillbirth and neonatal death. And during that work, we were able to extend our links to work with the team at the University of Manchester and PIL and replicate some of this work in Pakistan, which again is an area where you've got very high rates of stillbirth and neonatal death and not much evidence around parents' needs. So we're just in the process of completing an exploratory study in Pakistan. Just bring up all the boxes, please, on this.
1 minute left.
Thanks. So this is a qualitative study. We've conducted some interviews in Sindh province in 2 settings, in Karachi and Thatta. We've interviewed women and male partners who've experienced the death of their baby within the previous year, their family members and health workers who regularly provide care in this area. So data collection's been by one-to-one interviews. Next slide, please. So we've just got some emergent themes. The data is being analysed at present, but we found quite similar themes to our work in Africa around the profound effects of this on the parents, inadequate care generally in the facilities, lacking support, and several issues with the health workers around adequacy of training and also the culture within which they have to practice. Next slide, please. So just to summarise, our studies on being able to extend this work into Pakistan has provided key understanding which will help us develop interventions to support better bereavement care in Pakistan. Also, a very important part of this work has been around strengthening capacity in applied health research, including that for nursing and midwifery, which has been very underserved globally and particularly in low middle income countries. Many of the issues that have been identified in the exploratory studies have commonalities across global settings, which means some of the interventions that have been developed in high-income countries will be also applicable to low middle income countries with adaptation. And I think there's important knowledge that we're learning around culture and context, which may be transferable to taking back to the UK to support interventions that will improve bereavement care for Pakistani women and communities in the UK. And that's all I wanted to say. Thank you very much.
Thank you very much. That was really interesting. And again, people who have questions, they should add them in the chat, and then we'll try to respond at the end or via email. Our next speaker is Professor Cecilia Sau from Roehampton University.
Okay, thank you very much for inviting me to be part of this very exciting seminar. So I'm going to be talking about child and adolescent mental health research in primary care. Next slide, please. I'm going to be focusing on anxiety and depression. So anxiety and depression are among the most common mental health problems in children and adolescents. It affects about 10% of children and up to 32% of adolescents in the general population. They are very most common among girls than boys. There are a lot of speculation why this might be the case. One of them might be related to socialization, or in other words, the way in which girls and boys are raised differently. And then the other one might be related to the hormonal change. And yet there's some studies that shows that significantly more girls than boys are affected by life events. And we also know that adolescents, young people with anxiety and depression tend to have significant negative impact on emotional, social, and academic development. Next slide, please. What we also know is that young people with anxiety and depression tend to have other disorders. So what we see is the presence of comorbidity, which is almost like a rule rather than an exception. And this study was conducted based on on American adolescents, more than 10,000 of them. So we did a cluster analysis of 26 mental disorders. So what we found here is a high comorbidity within the emotional disorders, and that includes anxiety, depressive, and intermittent explosive disorders. But we also see a high presence of comorbidity within the behavioral problems. So that includes disorders like substance use in behavioral disorders, but surprisingly also with depression. So the next slide, please. We have been very interested to find out why comorbidity occurs. So in some of our recent papers, we have been using something called a network symptom analysis, where we are interested to see how the different symptoms across the disorder dynamically interact with each other. So one of the crucial symptoms or factors that connect the different disorders is related to low self-esteem. And in a paper that just came out 3 weeks ago, where we look at behavior and emotional problem, it's again, we saw low self-esteem and worry being quite central in connecting the different symptoms. Next slide, please. So we also know that anxiety and depression, they begin very early in life, and when these disorders are left untreated, they tend to have a chronic cause and outcome, and also they tend to increase the risk of developing other mental disorders in adulthood. And the slide on the left shows actually the fact that for depression, in other words, for those people who were born later, they tend to have a higher prevalence of depression than those that are born much earlier, like shortly after the Second World War or in the 50s, for example. And not only do they have a higher prevalence of depression, but when they have the depression, they tend to have it at the earlier age. Next slide, please. Next slide. So this is the study that we conducted some years ago. It's a 16-year follow-up. So we begin testing the children when they were 14 years old, and then follow them up to the age of 30. So, and we divided the age of onset of their, when they have their first anxiety. So before the age of 11 and after the age of 11. So what we have here is those that have an adolescence onset, so defined as the age of 12 to 18, they tend to have a higher prevalence of anxiety, depression, and substance use disorder at the age of 30. So what we also find is that those with the adolescence onset anxiety tend to have poorer psychosocial life at the age of 30. So this is defined as having poorer physical health, poorer adjustment at work, and have more problem within the family, less life satisfaction. And they also tend to have more chronic stress and have poorer coping skills. Next slide, please. Next slide. And this one is quite an interesting piece of work. This is based also on our 16-year follow-up study. So we were interested to find out what happened with those with depression. So for this particular paper, we were looking at following the children from the age of 14 to the age of 26, because we're quite interested in looking at emerging adulthood. So what we see here is 3 trajectory classes. So very interestingly is the one with the U shape, one on the top. So, and we were interested to find out what characterized those adolescents at the baseline, so at the age of 14. So what we found here for those with the U-shaped symptom class is that they tend to have high level of loneliness and have anxiety disorder and did not do, they did less physical exercise at T1 as compared to those with the other trajectory. So in another paper, what we found also is that lifestyle do play a very important role. So in terms of getting enough sleep, in terms of getting physical exercise, but also in terms of eating healthy food. Next slide, please. So what I've shown before is pre-COVID, and this is a study that we have done last year during the COVID period. What we found is that there are a lot of young people that, probably because of COVID being in lockdown, spending a lot of time on social media side, doing gaming, streaming services, and so on. Next slide, please.
Yeah, one more minute.
Yes. So one of the things that we did was also to find out what could influence that. We looked at the mother-child, parent-child interaction, and we saw a lot of correlation between children's symptoms and also caregivers' distress, and also caregivers also found problems within the family during the lockdown. Next slide, please. So we also look at the cohort. Our study was cross-sectional. So we also look at the Millennium cohort study. Millennium's cohort study is a longitudinal study. And just after the COVID last year, between March and May, they did a survey that looked specifically at the impact of COVID on children, young people, mental health. Next slide, please. So what we found here, again, we found four classes of disorders. So what we found very interestingly is at the age of 17, those that we categorize as having emotion dysregulation class. So those are young people that have bad sleep quality and mental health difficulties and symptoms, which we categorize as indicative of poor emotional regulation. They tend to do very badly in responding to the COVID lockdown. And also on top of that, those with high symptoms at the age of 17. Next slide, please. So I'm almost done. So what we have done is, because anxiety and depression are very common, we developed a transdiagnostic approach called Super Skills for Life. And the purpose of this is to make it as simple as possible and as short as possible. So the program is being implemented in 17 countries. We use the train-the-trainer model. And because of that, we have been able to train 25,000 practitioners worldwide, even during the lockdown, and more than 600,000 adolescents worldwide have benefited from Super Skills for Life. So next slide, please. Next slide. And there are various studies on that. Anyone interested, please contact me. So the next slide, please. Next slide. So this is a study done by our colleagues in Spain. So what they did was last year, they looked at the children who participated in Super Skills for Life before COVID kicked in, and then compared to children who did not receive Super Skills for Life, and see how they responded to the lockdown in Spain. So very interestingly, what they found is that those with who participated in the program before COVID, they actually cope much better to the lockdown, and they show less level of anxiety and mood, and less having a sleep problem. So next slide, please. Yeah, to summarize, then we can say anxiety and depression are common disorders in young people. And we also found out that those that have participated in our program showed significant reduction in anxiety and depression, and show improvement in their executive functioning. And as I mentioned before, more than 25,000 practitioners have been trained in the Super Skills for Life worldwide, and more than 600,000 young people are currently participating in super skill and have benefited from it. So thank you very much.
Thank you, Cecilia. Very interesting presentation. We would like now our next speaker is Professor Carina Lavelle from University of Manchester. Carina?
Hi, yeah. Am I sharing my own slides?
Yes.
Yeah. You've disabled it. You'll need to give me co-host rights.
I don't know whether I can do it. Dilip, are you there? Can you make Carina a co-host?
Yeah, I have met Carina course. Now she can share her slides.
Brilliant, thanks. Okay, can everybody see those?
Yes.
Yeah, brilliant. So I was asked to look at primary mental health care in the UK and its perhaps some of its translational effects. I will promise to keep to time, and thank you very much for inviting me. It's so great to meet new people and many people here that I already work with. So wanted just to say, you know, the whole level of
Carina,
whole mental health.
Slideshow. Can you press slideshow so that everyone...
Oh, sorry.
Yeah.
It's not letting me. I don't know why.
I think it should be on the low, on the bottom ribbon, and there's an image there to slideshow.
Yeah, I normally do it at the top, but I don't.
Okay, sorry.
No.
Basically, there is an option file, home, insert, design. Then if you move towards your right, you will see slideshow.
Yeah, slideshow.
Yeah, I normally have it on the top ribbon, though. It's not there.
It's on the same row that you're right now. This, just below that. File next to it. Anyway.
No.
It's the seventh item on the ribbon on the top, Carina. So where your file is, home, insert.
Yeah, you see, normally it's there, but what I can't do is I can't see it.
We can see it on your screen.
Yes, it's fine, Carina.
Yeah, it's fine.
Let's go ahead with this.
Okay, I'm really sorry because I can't find it. I don't know why.
No worries.
So some of the sort of common mental health problems, you know, are mixed anxiety, depression, which is our biggest. Then we've got depression, and then we've got anxiety, which includes generalized anxiety, panic disorder, phobias, health anxiety, PTSD, medically unexplained symptoms, obsessive compulsive disorder. We know that there's a massive scale of this problem. Our last speaker talked about children, adolescents. I'm more talking about adults. We're probably looking at about 16% of the population with these difficulties. And the total economic burden due to lost work and absenteeism associated with depression and anxiety is around 12 billion a year. And it's this mixed anxiety and depression which is the most common, with almost 9% of people meeting criteria. So this is the criteria rather than people are on the border. So just briefly in terms of primary mental health care, you know, we know that it's around 30%, though it's probably more if you bring in medically unexplained symptoms, relate primarily to mental health problems, although many people present with physical problems. this vast majority of people experiencing mental health problems are treated in primary care, and patients prefer talking therapies. And a number of years ago, there was a lack of expertise in evidence-based interventions in primary care. So what were the, if you like, the key principles? So where did people start? Because it was a bit all over the place. You know, there were CBT units, but it was a really uncoordinated response. And the, if you like, the government swung between secondary care with people with psychosis to primary care, back to psychosis. So it was all, what did they want, I guess, from, this is around 2005, 2006, people wanted high volume because of our waiting list was so long. So they wanted to look at low intensity interventions. They wanted to focus on common mental health problems, and they wanted an effective, accessible and acceptable interventions, which early 2000s were more focused on CBT. And if you, one thing that I'll take from this, because people can have the slides, is that step care was adopted as the main framework for delivering services in primary care. And then sort of meeting demands. So if you like, we had a step care, which I'll talk about in a minute. It was this huge system that's set up, which was the IAPT, which is increasing access to psychological therapists. It's now well embedded in England. And we have PWPs, which are, if you like, deliver low intensity therapists. They're not health professionals, they have a year at university. And then we have something called HITs, which are high intensity, which is sort of CBT counselling. Tell me when I've got to stop, Maria, because I know that you're, but what, you know, what is step care? Well, it's a US concept. There are two main features: that if we were going to give a treatment, then it should be the least restrictive, but needed to produce significant gain. And it needs to be self-correcting, and that's something that's really important. So used outcome measures and decisions about further treatment. And there are assumptions in step care. There's an equivalence assumption, there's an efficiency assumption, and there's an acceptability assumption. And there, if you like, what the assumptions are. I'm going to move on a bit just because of time. So IAPT was originally launched in 2008. It was a huge, large-scale initiative that aimed to significantly increase the availability of NICE recommended psychological treatments for depression and anxiety disorders within NHS Commissioned Services England. And I don't think I can say how influential IAPT's been and how many people it's helped. And it is a system now, you know, we've got so many IAPT services all over the country. And really what it does, it provides, its aim is to roll out NICE compliant, low intensity psychological and high intensity psychological intervention services, including expanding some of the sort of specialized services. The workforce of psychological therapists has expanded beyond recognition from 2008. And the programme aims to obviously improve patient recovery and employment rates.
Carina, 1 more minute.
Okay, so this is their vision: in a universal equitable service, personalised care, efficient services and effective services. And I guess the sort of biggest headline, now we're in 2021, is transform the treatment of adult anxiety disorders and depression in England. Widely recognised as the most ambitious programme of talking therapists in the world. And if you just look at 2020, more than 1 million have accessed it. just want to say a bit about primary care at Manchester, which many people here have been on, but we've looked at maximising access to care. And these acronyms are just trials, but we've done computerised, low intensity treatments. Many of us here in Manchester have led these low intensity treatments. We've looked at remote working, and this was prior to COVID. We've looked at integrating mental and physical care in terms of integrating collaborative care, health coaching, remote delivery. And then we've looked at prevention of primary care with, if you like, unexplained medical conditions. So hopefully I just kept in time for that. So thank you very much for listening. Happy to answer any questions that you might have.
Thank you very much, Carina, for this excellent overview. And people can add questions at the chat, and then we can see whether we can discuss some at the end or send you via email. Our next speaker is Dr. Indy Qureshi.
Hello, thank you. Dilip, do you have my slides?
Yes, let me share my screen.
Great. So let me start. So thank you, first of all, for inviting me. Hello and assalamu alaikum. I want to spend the next 7 or 8 minutes just quickly running through a trial we undertook with our fantastic research team in Pakistan. So that's our PIL colleagues. We've heard about capacity building, translational research, and some amazing presentations on psychosocial interventions. This is a biological intervention looking at a group who are at high risk of developing psychosis. That group is variously known as an at-risk mental state group. So these are individuals who, by virtue of maybe a genetic history or have a predisposition to developing a schizophrenia spectrum disorder, or maybe are already experiencing brief and short-lived transient psychotic symptoms. And why is that important? Well, we know that if these individuals are tracked over a year, approximately 20% will develop a schizophrenia spectrum disorder. We've heard about prevention. Prevention is very important. So we know that if we intervene during this critical period, perhaps some of the long-term harmful effects of psychosis, particularly in terms of occupational and functional outcomes, can be prevented. I just want to mention particular PIL colleagues, Amir and Taiba, who I think are on the call. Without them, this trial, this ambitious multi-center trial would not have been possible. Next slide, please. So this is our protocol. We don't have time, I'm afraid, to go through it in any great detail. Suffice to say, it was a multi-center randomized placebo-controlled trial across 3 large urban centers in Pakistan. So very ambitious in nature. Again, issue of collaboration, and the trial wouldn't have been possible without successful collaboration between colleagues here at the University of Manchester involving Nusrat, Imran and Bill Deakin, and colleagues at PIL. So it's biological research. So we've heard from Professor Rahman about some psychosocial interventions. This is looking at compounds. So the 2 compounds which we chose were minocycline, which is a widely available antibiotic, and omega-3 fatty acids. Because at the time this study was conceived, there was evidence that these compounds, which have anti-inflammatory properties, so there's persuasive evidence that schizophrenia in particular is mediated in part. So the causal pathway in many individuals we think with schizophrenia is abnormal inflammatory processes. So minocycline and omega-3, I won't go into the details, have anti-inflammatory properties. And more importantly, they're widely available in lower middle income countries, and equally importantly, they're safe. So they're used in other treatments, in the treatment of other disorders, So this is an example of a repurposed drug study. And finally, I know we have the Consul General of Pakistan. I think it's important to make an observation as the chief investigator that ambitious multi-center studies of this kind require funding. We were fortunate to receive funding from a charitable organization in North America, the Stanley Medical Research Institute. Next slide, please. Apologies for the busyness of this slide. This is a consort diagram, essentially a visual representation of participant flow during the study. I just invite the audience to look at the top 4 boxes in particular. So a huge number of participants were screened, demonstrating the research capability of the research hubs hosted by PIL in Pakistan. Essentially, I live in a very small town in England of about 10,000 population. Everybody in my town would have been screened because 10,000 participants were screened. And why is that? Well, the group who were interested are very difficult to find, particularly in lower middle income countries. So we undertook a 2-stage screening process, eventually finding 326 participants who were randomized. And again, just pausing at that number, 326 participants entered the study. And that compares very, very favorably with intervention studies, drug studies, and psychological studies of at-risk mental state undertaken in America, Europe, and here in the UK, and again demonstrates the ability of research networks in Pakistan to undertake these large-scale drug studies. So we followed up participants over 12 months. I won't go in any specific detail, conscious of the time. We undertook a number of outcome measures, and our primary outcome measure was how many individuals transitioned to psychosis at 12 months. And our hypothesis was that the group who received omega-3 and minocycline in combination would have much reduced transition rates compared to the placebo group. The results are currently being analysed. We've written the paper in May, and we hope to submit it for publication early next year. So watch this space. Final slide, please. So instead of focusing on the results, I thought, what does this study demonstrate? So I like the fact that we worked in close collaboration with our research colleagues in Pakistan. This was an ambitious trial, which here in the UK would have cost multi-million pounds to undertake. There was value for money undertaking it in Pakistan. We demonstrated the ability in terms of managing large data sets and maintaining integrity of the trial in terms of delivery. And it's been a privilege to work with colleagues in Pakistan, and it demonstrates, I can see the title of this symposium is Global Challenges, Manchester Solutions, and I think hopefully this is a small part of that overall strand. Thank you very much.
Thank you very much, Indy. A very impressive trial, and we would like to invite Oslem Ailem, who's next, from Queen Mary University.
It's Maria. It's going to be Tayyaba. Autumn has not been able to come, so Tayyaba will be presenting.
Shall I make a start, Maria?
Yes.
Thank you. Hi, everyone. I am Tayyaba Kiran. I'm clinical psychologist, and I'm working with Pakistan Institute of Living and Learning as Assistant Director for Research and Development. I will be talking about digital mental health and suicide prevention, with particularly with reference to our context in Pakistan. So as Dr. Sohag has already mentioned, Pakistan is the country which is home to more than 200 million population. We are amongst the country with poor mental health indicators, with less than 500 psychiatrists for this population size. But on the other side, we are a country where universities from across Pakistan are producing a large number of psychologists each year, though the psychologists are underutilized in the country at the moment. So with this limited number of the psychiatrists and underutilization of the huge resource of psychologists, there is a massive treatment gap in Pakistan. As World Health Organization said that Pakistan has more than 24 million people who need mental health assistance. And as Professor Rahman has already mentioned, that 90% of people with common mental disorders are left untreated in Pakistan. So considering this massive treatment gap, the next question for us is to explore whether digital mental health can be a potential solution to combat this mental health crisis in Pakistan. If we look at the telecom indicators in Pakistan, we are a country with more than 183 million mobile subscriber at the moment, and there is a large number of population who have access to internet in the country at the moment. So based on these telecom indicators and the work done by Dr. Nadeem Gayer in UK for development and assessment of mobile-based intervention for treatment of psychosis, we have used the same footprints, and we have developed and assessed the feasibility and acceptability of a mobile intervention that we call Tech Mother Care to reduce maternal depression among mothers of young children from birth to 3 years. So for this feasibility trial, we recruited participants from 3 cities across Pakistan, and this mobile intervention is integration of 3 key elements. The first aspect of it is momentary assessment that involved assessing mothers in real time for 4 states, like one item about depression, then anxiety, sleep disturbance, and suicidal ideation. The second component of this Tech Mother Care intervention is generic messages. So these messages were received by all the women who were in the part of intervention arm of the trial. One message each day was about learning through play, which is a parenting intervention that helps parent to provide stimulation to the child for development in 5 different areas of child development, like sense of self, cognitive development, language development, development of interpersonal relationship. And the plus component is about the Thinking Healthy program. Again, Professor Atif Rahman has already talked about it. Third, but very interesting component of Tech Mother Care intervention is intelligent real-time therapy. So this component is only for those moms who have responded yes to momentary assessment that I have just mentioned. So as part of intelligent real-time therapy, there was a specific package for each of the 4 symptoms: depression, anxiety, suicidal ideation, and sleep disturbance, that was individualized for a set of population. As we were working with the vulnerable population, so one aspect of Tech Mother Care intervention was the crisis plan, where the participants who were at risk were referred to the nearby psychiatric facility in the town. So some findings from the qualitative work that we did at pre-intervention stage was participants suggested that pictures could be a safest way to illustrate the message, and they were of the way that intervention should include a component to help them to deal with interpersonal conflicts, and it should be available in Urdu. From post-intervention, participant reported that the intervention was acceptable, as one of the participants said that ease in mobile, in that we have it with us all the time, and we can see and read messages and can get knowledge while sitting at home. They valued Tech Mother Care intervention and said that this intervention has helped them to feel good about themselves. So on similar lines, the integrated, Sure, Maria. The integrated intervention was delivered through another mode that was over a telephone call. Again, it was found to be feasible and acceptable. So on same line, we are now using the digital platform for self-harm and suicide prevention, particularly in primary care setting, as these are the settings that are frequently approached by those who are at risk of committing suicide. So we are adapting the existing CMAP intervention through patient and public involvement and engagement for those presenting with suicidal ideation in primary care settings. And we will co-develop a mobile app that we call CAMI and will test in a 3-arm randomized controlled trial. And similarly, another existing intervention that we are currently testing in a face-to-face conventional method across Pakistan. And the idea is to develop, again, co-develop the mobile application of using existing by CMAP intervention for those young people who are presenting with self-harm. So that's all from my side. Thank you, everyone.
Excellent, thank you, Tayyeba. Dr. Amy Blakemore from the University of Manchester is next.
Hi, everyone. I'm just going to attempt to share my slides. Can you see those? Can everyone see those?
Yes.
Yeah, okay. Hi everyone, good morning or good afternoon. My name's Amy Blakemore. I'm a lecturer in mental health at the University of Manchester. And I'm really pleased to be presenting to you today on behalf of the newly formed Older Adults Multimorbidity Group, which has recently been set up as a collaboration between PIL and the University of Manchester. This presentation today is really an opportunity for me to showcase some of the ongoing and developing work that the group are involved in to help to address the important issue of multimorbidity in older adults in Pakistan. So multimorbidity, as I'm sure most people are aware, is the presence of 2 or more chronic conditions which are occurring in the same person at the same time. The chronic conditions can be either physical and or mental health conditions, and multimorbidity overall is presenting an ever-increasing global health challenge, which is placing a large burden on both individuals and healthcare systems. There is a rising trend in the prevalence of multimorbidity in low and middle income countries, with one recent systematic review estimating a prevalence of up to 90%. A longitudinal study of over 16,000 urban living adults in South Asia, which included a recruitment site in Karachi, found a prevalence of 37% of multimorbidity in those aged over 60 years. The risk factors found for multimorbidity in this study were having a high BMI of over 25 or over, higher waist circumference, drinking alcohol, and having a family history of chronic conditions. They also found that the risk of death was twice as high in those with 2 or more conditions, and 3 times as high in those with 3 or more conditions. So I'm sure we can all agree that multimorbidity presents a real challenge to us globally and equally in South Asia, and is an extremely important issue for us to address. So as I said, I'm presenting today on behalf of the Older Adults Multimorbidity Group, which was set up earlier this year to provide a space for researchers and medics from PIL and the University of Manchester and other academic institutions in Pakistan to collaborate on the development of new projects to address issues surrounding multimorbidity, particularly in the area of physical and mental morbidity. Also to provide support for ongoing projects in multimorbidity, which I'll be able to show you more about across the next few slides, and to increase capacity and capability for research in the area of multimorbidity in Pakistan. You can see the core members of the group listed here. However, we also regularly receive input and collaborate with external academics and medics. So our initial scoping work and a review of the ongoing studies in the area of multimorbidity that the group are already involved in have meant that the group has focused its work in the areas shown on this slide over the last 5 months. Sorry, I've got a really chesty cough. Today, I will be able to tell you more about the CHD and depression study, coronary heart disease and depression study, the Moving On ABC study, and developing work in the areas of COPD and depression and anxiety. Members of the group are also currently working together to develop projects around stroke and suicidal ideation, diabetes and depression, long COVID, and early psychosis and sleep disorders. So starting off with the coronary heart disease cardiac rehab study called Across. So we know that cardiovascular diseases are a leading cause of death and disability worldwide, predicted to contribute to 80% of the burden of disease across low and middle income countries by 2030. Cardiac rehab is a proven model of secondary prevention, which is shown to reduce mortality, hospital admissions, and improve health-related quality of life and mental well-being of people with heart disease in high-income settings. So Across aims to develop an affordable community cardiac rehabilitation programme to reduce mortality and morbidity from coronary heart disease in Pakistan. It will do this by exploring knowledge and attitudes of Pakistani healthcare professionals about community cardiac rehab initially, exploring lived experience of cardiovascular disease patients and family members, and exploring health professional views about home-based cardiac rehab. The study design, as we have running at the moment, is an exploratory mixed methods cross-sectional study with 2 phases, including a cross-sectional survey of healthcare professionals and then in-depth qualitative interviews with patients and healthcare professionals. As I said, the study is ongoing. This part of the study is ongoing and is led by people who are in attendance here today and brought for discussion within the older adults and multimorbidity group by Dr. Manazet Abeid. The aim is to use this preliminary work to develop and trial an adapted version of cardiac rehab that's both acceptable and feasible for CHD patients in Pakistan. So the second study I'm going to mention today is called Moving On ABC. Moving On ABC aims to address the efficacy of integrating culturally adapted CBT with an intervention called Moving On After Breast Cancer, and is recruiting currently across 5 centres in Pakistan. The Moving On ABC intervention was developed by Dr. Anila Salim and offers practical support on living life after breast cancer, using mindfulness techniques, addressing fatigue, understanding patients' illness beliefs, improving personal relationships, and implementing relaxation techniques. This work is vital in Pakistan as it has the highest age standardised incidence rates of breast cancer in Asia, and many women with breast cancer experience significant impact on their mental health. This might include increased rates of depression and anxiety, trauma, and impact on their self-image and body image. This trial is well underway. You can see the recruitment flow diagram here. The team aimed to randomise 354 patients from both primary care and specialist cancer settings and are now close to that target. The protocol for the trial is currently in submission, and we look forward to being able to see and discuss the results in the not too distant future. Third area that I wanted to focus on from the work of the older adults multimorbidity group today is around COPD and mental health. We're developing projects in this area, following on from a large cross-sectional study that was conducted in Pakistan a couple of years ago, which was published this year, as you can see the references on here. The study found that the prevalence of depression among people with COPD was 51%, and the prevalence of anxiety among people with COPD in this study was 20%. And it also found that participants with depression had significantly higher levels of anxiety, less social support, reported high levels of social stress, and a greater impairment in their health-related quality of life, which is a really important predictor of outcome in patients with COPD. And I'm sure there's also no doubt that these patients would make greater use of urgent healthcare services, as we've shown in UK studies that depression predicts use of urgent healthcare in COPD patients. And they would also experience higher levels of morbidity and mortality as well.
1 more minute, Amy.
Thank you, Maria. Okay, so based on this cross-sectional study and other scoping work has been conducted in Pakistan, Mariam, who's here today, is currently seeking approval for a factorial randomised controlled trial to test pulmonary rehabilitation combined with CBT for depression and anxiety for COPD patients in Pakistan. We know from global studies and international guidelines on COPD that pulmonary rehab is the most clinically effective and cost-effective intervention to improve outcomes and health-related quality of life in COPD patients. However, it's not routinely available for patients in the community in Pakistan and is not being tested there when combined with CBT to specifically address patients' anxiety and depression, which we know also predict health-related quality of life, functioning and outcome. Alongside this work, we're also developing a study in the UK to address barriers to pulmonary rehab and culturally adapt the intervention for British South Asians with COPD. As we know, rates of uptake for pulmonary rehab for British South Asians in the UK are particularly low. So just to finish off, and in summary then, that was a bit of a whistle-stop tour of some of the ongoing work being supported by the older adults and multimorbidity group. We know that multimorbidity will present an increasing burden in Pakistan. We think that there are many opportunities that exist to increase primary and mental health research in multimorbidity in Pakistan. And the older adult group is a relatively new group that's already begun to work collaboratively to identify and address gaps in healthcare provision. But we know that further work is needed to identify other key priority areas, develop high quality studies, and also to focus our attention on the implementation of effective interventions for multimorbidity within Pakistan as well. Thank you.
Thank you, Amy. An exciting new group. And our next speaker is Professor Imran Kaldri from Peel. Oh, sorry, from yeah.
Thank you very much, Amy. So my slides. Assalamu alaikum and good morning, everybody. It's a privilege to be here. A very special thanks to Maria, Nusra, and wonderful to see Kay and other colleagues from University of Manchester. So I'm going to be talking to you about mental health research network in Pakistan and the work we have done in severe mental illnesses and the opportunities we have over the coming years to further this work across Pakistan. I'm privileged to be part of University of Manchester since 1994 and continue to be affiliated with it. And I think this is a proud moment for both University of Pakistan and Pakistan Institute of Living and Learning to be able to see what we have seen in the last 1.5 hours, the mammoth amount of work that has been done, which has put Pakistan on world map in mental health research, and really chokes me when I say that yes, Manchester has made a difference in research in Pakistan, especially University of Manchester, and I'm proud of that. Next slide, please. So I'll be talking to you about quickly about some work we have done in schizophrenia and bipolar disorder. Schizophrenia, as we know, is a severe mental disorder. It's very disabling, debilitating, with mammoth effect on society, individual patients themselves and their families. Unfortunately, stigma and discrimination is significant and leads to delay in treatments. We need to, with the success we are having with studies and trials, to be the advocates that schizophrenia is treatable, not just with medication, but psychosocial interventions as well. I'll be talking more about the pharmacological, the biological side. Next slide, please. And the next. So my journey started with the University of Manchester and Pakistan and Peel and in 1994 when I first joined the university. And the first study was my doctoral work of cyproheptadine in neuropsych in patients with schizophrenia. This was then followed up by the first intervention study in Pakistan in 1998, amoxicillin as an antipsychotic in comparison to haloperidol. Now, this is a study where Professor Beldeacon, Professor Satish Kupu from University of Toronto, they were involved. And this is really one of the very first clinical intervention trials and a successful trial. So I'm not going to be presenting individual data, but just to give you a flavor of the range of the mammoth amount of work that has been done. Next slide, please. We then went on to do this minocycline as an add-on in patients with early schizophrenia. It was a successful trial funded by Stanley Medical Research Foundation. And based on this results from this study, we got this mammoth grant from EME and MRC the results of which are published in Lancet Psychiatry in 2018. And this was done in the UK, across the UK, and the credit goes to the study that was done in Pakistan through PIL by University of Manchester. Next slide, please. Then we went on to look at simvastatin and ondansetron, anti-inflammatory agents in schizophrenia. We did a small pilot study, which led to a very large grant from Stanley Medical Research Institute. And that work is, the manuscript for this is under final stages in preparation. We found some improvements in symptomatology with ondansetron, but not with both. Next slide, please. So Maria, I'm hurrying up, conscious of time. So then we went on to do this study that Indy has very elaborately. Indy is one of these bright young scientists that we are privileged to work with, for which he's given you a flavor of omega-3 fatty acid and minocycline in at-risk mental state. A study that I'm proud of is the next one, the methotrexate. As you know, methotrexate is a cytotoxic compound. It's used in cancer treatment. It's also gold standards in rheumatoid arthritis. We are the first group in the world to publish intervention of a cytotoxic anti-inflammatory agent with positive results anywhere in the world. And the work has been done in Pakistan, funded by Stanley Medical Research Institute. Next slide, please. Now, as I talk of budding scientists, this is another amazingly bright young Ishrat Hussain, University of Toronto. So he led this study and along with us from Manchester, PIL, a very successful trial of minocycline and celecoxib in bipolar depression. He was also lead in, we just finished and published this treatment intervention of simvastatin in depression, treatment-resistant depression. Next slide, please. We are also interested, while we are looking at schizophrenia, early schizophrenia, and treatment-resistant schizophrenia. So we did publish some case studies with Indy Qureshi of using minocycline augmentation with clozapine. And now an intervention study has just been finished in Pakistan, the results of which have been now been done and hopefully being written up. We are also just finishing up this, when it finished the study of using minocycline as an adjunct in treatment-resistant depression. Next study, next slide, please. So these are all psychopharmacological intervention studies. There's a range of at least 13 to 14 studies that we have done since we started in collaboration with University of Manchester. Let me take you in 2 minutes to some this research-ready team. And based on this is, thank you for this slide, is we are privileged to, in January 21, that we initiated the Pakistan's first mental health research network. And the mission is to explore opportunities for joint collaboration to carry out large multi-center studies in Pakistan. Next slide, please. So evidence for imaging and genetic study. Next slide. So with this, I want to say that we are moving on from just pharmacological intervention to more biological research, looking at imaging and genetic studies from Pakistan. Next slide. So just to give you a bit of flavor, there's not much imaging work done in Pakistan. There's very few published studies. One of them is our colleague, Professor Heather Naqvi. Then a number of large, next slide, please, multi-center studies that have been done to understand the underlying mechanisms of chronic illness. Now, this is a slide that I want to just spend 10 seconds on. Another budding psychiatrist, absolutely privileged to work with, these young, amazingly bright scientists. Omer Hussain, who's assistant professor at the University of Toronto. He's got this grant for synaptic density as a trademark in a clinically high-risk group, where he's also leading a work for similar study, replicating it in Pakistan. Next slide. So we've also got a pump priming award with Dr. Leroy to strengthen brain health research in Pakistan. And based on that, next slide, the work that we actually had applied for a large NIHI grant. We were not successful, but we continue to, but the feedback was very encouraging. We are continuing to knock on the doors to try and get into some funding for research in this area. Next slide, please. So this is it's really a fast forward journey of 27 years of PIL and Pakistan working together in Pakistan. So thanks to all our participants, service users, our collaborators, co-applicants, and our funders, and particularly the University of Manchester, that what amazing work has been done in these last 27, 25 years. Thank you very much.
Thank you very much, Imran, for this amazing showcase of this excellent studies. So let's move to the next speaker, who is Professor Saeed Farouk from Keele University.
Okay, thank you very much. And it's a privilege to be speaking on this forum. Grateful to Nusrat for giving me opportunity to talk about digital mental health and severe mental illness. And I must say that Nusrat's presentation, Imran's presentation has set the scene very well. And I have the privilege to be working with Nusrat and know their tremendous contribution, especially the Manchester's contribution to mental health research in Pakistan. What I'm going to do quickly in a few minutes is I'm not going to talk much about the research we have been doing because it has been talked a lot about it. I'm just going to identify a major research opportunity for digital mental health and severe mental illness in Pakistan. Next, please. So basically, what is the challenge at the moment? We have talked about the research, but what is the challenge? Let's grapple what's the challenge. The challenge is the treatment gap for severe mental illness. I think without going into the technicalities of the definition of SMI, severe mental illness or serious mental illness, as it's sometimes called, has a prevalence of about 4%. And with a Pakistan estimated population of over 220 million, there are about 9 million people with severe mental illness in Pakistan. So and that is greater than the population of Scotland and Wales put together. So that is the scale of the problem we are facing. So there's a population greater than the Wales and Scotland with severe mental illness who are requiring treatment. And there are WHO estimates for treatment gap in low and middle income countries. And for Pakistan, the gap is much higher. But if you take the median gap estimated by WHO, it's about 70%. So with 70% treatment gap, there are about 6.3 million people with SMI in Pakistan who are not receiving any treatment. And again, just to put in perspective, that is the greater than the population of Scotland. The Scotland population is 5.5 million. So a population greater than that of Scotland in Pakistan is currently not receiving any care for severe mental illness. So that is the huge challenge, and that is, I think, our research should be going. So next, please. So what are the opportunities? There are a lot of opportunities. I will just talk about one opportunity, and that is the digital mental health and the increase in the digital technologies in use in Pakistan. And as you can see, I think it has been shown previously as well, there is a greater uptake of the mobile band and the internet, and it's picking up. Still, there's a large gap that a large population is covered by the by mobile phone internet. But there is even greater opportunity recently, and that is, next please, and that is this, which, next please. Yeah, so there is a SAS program. I don't have the time to put, but I would to go into the detail, but I would request those of you who are interested to go and visit the SAS program website in Pakistan. To put simply, SAS is the largest targeted subsidy program started by the government of Pakistan. And that has an indicator for the poverty reductions as well as the indicators of the people who can be subsidized through financial subsidies. And within the SRs, there is a big program called Data for Pakistan, which has, for every district, it has the data for the people who are below the poverty line, who have certain poverty indicators. And that data is available for almost all the districts of the Pakistan, and that is being used for providing the funding support from the government. And that is a huge database, which I think can be linked for providing care for the severe mental illness. Next, please. And how the care for the severe mental illness can be provided. Again, I've been working for almost now 2 decades on developing a model for providing care for severe mental illness. We first developed this approach called supervised treatment in outpatients for schizophrenia, in which a family member is trained involving the primary health care and who supervises a person's treatment in the community. We first showed the effectiveness of the approach in a trial which was published in British Journal of Psychiatry. And now we are scaling up that program. The full protocol is available. The sample size for this trial is 526, and we should be having the results in April 22. So basically, this is a model which involves the primary care family members in supporting the treatment and in providing the access to the treatment. And it has been shown to be effective in the previous trial, as I mentioned, and we should be having a large-scale study to show how it works and what are the processes in implementation. So next, please. So what I'm suggesting is, next, please. This is what I'm simply putting, that we should be advocating with the government of Pakistan to include the diagnosis of severe mental illness as one of the eligibility criteria for those who are registered in the SRS program, so that they can become eligible, because about 70% of those people who are having a severe mental illness, A, do not have the access to the treatment, and B, they are usually more than 50% of the population are living in poverty. So we need to include the SMI in the SRS program, and then link all those suffering from SMI for assistance with the SRS program, and then provide them treatment using the STOPS approach or a similar approach which has effectiveness. I'm not just focusing on STOPS. Support the families in the vocational and financial assistance. As I mentioned, the SRS program not only provides the financial assistance, it also provides the vocational support. And I'm sure His Highness High Commissioner of Pakistan, who is present here, he must know, he knows what the SRS program is. It's a revolutionary concept. So next, please. So in conclusion, what I have identified is that we have effective intervention. The biggest problem we have is the implementation gap. We have the effective implementations. As Imran's slides has shown, they have done tremendous work in research in Pakistan. I think the next leap we need is the implementation research. And this is one of the possibility of linking the severe mental illness to the Data for Pakistan program and providing them a complete free access to the treatment, which can result in a unique public health model for treating the SMI in low and middle income countries. This targeted subsidy program is based on vision of Imran Khan, the Prime Minister of Pakistan, and should encourage the inclusion of the severe mental illness in SRS, as well as bring it at the primary care level, because the STOPS approach is based in the primary care level. So what I'm suggesting finally is, and that will provide the biggest opportunity for implementation research and its finding, that if we are able to develop a cohort of people identified and supported through this program, it can provide the data and evidence for reducing the treatment gap for the SMI worldwide, especially in low and middle income countries. Next, please. So thank you very much. As I said, I just talked about the opportunity. I'm not talking more about the research. There's a lot to say. And hopefully I feel that in presence of so many people from Pakistan who are doing excellent work, an opportunity like this can be grabbed and people with SMI can be provided care in the community. Thank you.
Thank you, Said. And I think it provides a very nice combination with the previous presentations. Now we've got Professor Naseem Kaldri from Dow University of Health Sciences and Peel in Pakistan as well.
Thank you, Maria. Fascinating day, fascinating talks. Pleasure to be here. Also very happy because I am a Manchester University alumni and was associated with it as a senior lecturer for a number of years. So today I want to share work that Pakistan Institute of Living and Learning with the University of Manchester has been doing on self-harm and suicide prevention. I'm going to focus on a project called SEHRM, South Asia Harm Reduction Movement, because this work has led to a national platform for mental health research in Pakistan. Next slide. So very briefly, people have been hearing about Pakistan Institute of Living and Learning. We are a not-for-profit organization. Our mission is to improve health and well-being of our people, in particular their mental health. And we work on looking for safe, effective, culturally appropriate solutions for mental health issues through research. We are based across Pakistan. We have our team bases in 7 major cities of Pakistan. Next slide. And we work across the life course. So we work from preconception, pregnancy, postnatal, early childhood, early adolescence, young people, working adults, older adults. We work across all DSM-5 divisions, and we have a number of cross-cutting themes that work across these divisions as well. Next slide. Suicide remains a global health concern. 75% of people who die from suicide, it happens in low and middle income countries like Pakistan. So our self-harm work, like our biological work, started a number of years back with a small feasibility trial where we looked at the effectiveness of a culturally adapted, manual assisted problem-solving training for people who self-harmed. On the basis of this, MRC gave us a grant to do an RCT across Pakistan for this intervention. We were able to randomize 901 adults who presented with self-harm and suicidal ideation and attempted suicide. And then MRC again funded us for doing similar work, but on young adolescents. And we've recruited, because that work with our young adults is near completion, and we've randomized 684 participants for our young adult study. So this work, our earlier work, led to a GCRF substantial funding for a project that we are doing with colleagues from UK and India called SASHI, South Asia Self-Harm Research Capability Building Initiative. And SEHRM, the project that I want to focus on, is a part of this larger work. So in our SEHRM work, there are 6 work packages. Work package 1 is around capacity capability building, which is hugely important for us. Since SEHRM, we've done structured training on research ethics and governance, biostats, health economics. We've developed a 6-month course on fundamentals of health economics with Pakistan Institute of Development and Economics. Our work package 2 is we are doing first ever national morbidity psychiatric survey across Pakistan. We'll be including 11,000 households. And this is on the footprints of the National Morbidity Psychiatric Survey for UK. The work has started. We've completed data collection in Gilgit-Baltistan, and data is being collected in other provinces. Our third work package is self-harm and suicide routine data collection. Pakistan does not report its stats on suicide to WHO. So we really don't know what the quality of data that is being collected. So we'll be approaching public hospitals, coroners, prison settings, faith-based organizations, basic health units, and many other sources to gather this information on routine data. Next slide, please. Qualitative interviews. In a previous young adults and CMAP work, we've already done a number of qualitative interviews. We'll have further qualitative interviews in our feasibility studies that we are doing under the remit of SEHRM and in a household survey as well. Our work package 5 is evidence synthesis. Not many people do systematic reviews in Pakistan. In SEHRM, we've started delivering trainings on how to conduct systematic reviews. We've already published a systematic review on use of mobile and internet-based interventions for prevention of self-harm and suicide. And because of time, I'm not going to go, but we are doing a number of SRs under this work package. Some are already registered on Prospero. We are also doing a number of feasibility trials with vulnerable groups like first-line health workers, burn victims, refugee moms, adolescents with autism. Next slide, please. Now this work, and you've heard Imran talk about, and you've heard others talk about work that Pakistan, along with our collaborators, University of Manchester, being our biggest, our closest, and our longest collaborator. So we are doing amazing work, but this work we are not doing on our own. This work is based on our years of partnerships and collaborations, starting from community leaders, imams of mosques, to vice chancellors of universities, to third sector organizations, and many, many others. I'm only going to talk about a couple of these. Sustainable Development Goal Task Force. The SDG lead is a big supporter of our work. He's a psychologist by background, and he's the one who's recently moved a bill in the Senate for decriminalization of suicide, because suicide is still a criminal offense in Pakistan. We have recently opened the first Center of Excellence for Research in Self-Harm and Suicide Prevention with Fatma Jinnah Women University. We are liaising with Dow University of Health Sciences for establishing a Center of Excellence in Research for Parental Mental Health. So amazing partnerships and amazing work going on. Next slide, please. All this work has led to University of Manchester, SDG Task Force, and Pakistan Institute of Living and Learning organizing a summit, all-parliamentary mental health summit, hosted by the President of Pakistan at the President House, where we were tasked to develop Pakistan's mental health policy and implementation plan. So that work is going on. And next slide, which is my final concluding slide. So I think I just want to end with, we have to remember, we started from the participants, and our work, our journey over these years, both biological, psychosocial, with amazing collaboration from University of Manchester, Nusrat Hussain in particular, has led to the highest level of parliament. So thank you, everybody. Thanks to participants, funders, collaborators, and thank you.
Thank you very much, Nassim. I wouldn't think of a better way to conclude the presentations today. So thank you very much for this overview. And I would like now to invite Mr. Mohammad Tariq Wazir for some concluding and comments and remarks. And after that, Professor Nusrat Hussain.
Hello, good afternoon, everybody. We started with good mornings, and we are concluding after 2 hours. Wonderful, wonderful session. I absorbed so many things, so many things that it's quite difficult to even pick the best out of them, because all the interventions and all the inputs were amazing. Kudos to Mr. Hussain. Kudos to his team that you have managed to bring all these amazing people together on this page. And I have learned so much, and I think I'm a wiser person after this session. I think we have to celebrate this union of ours, if I may, because you find elements of psychology, you find elements of biology, and this combination is extremely important for any intervention in terms of the topic that we are talking about. I also want to say this, that myself sitting here in Manchester, myself sitting here as representing the government of Pakistan in this city or for this Northwest region, I've already said this to Nusrat Hussain, Professor Nusrat Hussain, that I'm available. Anything that I can do in my capacity, I'll be more than glad. But more than that, the thing that makes me happy is to find so many leading people in different fields, thinking on the same lines and trying to chip in with their little bit that they can. Here, I think on an institutional basis, I think the whatever is happening, different institutions are involved in this. Specifically, the University of Manchester. I think I'm an Oxford University alumni, but if I had a chance, if I could go back and make a choice between University of Manchester, now knowing what it is doing in different fields, I think I would have gone for the University of Manchester rather than University of Oxford. So that is something that I think I'm very happy about, and I want to mention Jinnah Clinical Academic Appointments and their collaboration with the University of Manchester in doing the amazing job that they are doing in Pakistan. There are so many things that I could narrate here, and I think it will take another hour for me to say good words about your interventions today. But one thing that I'm not a scientist, I'm a generalist, if I may, as a diplomat. But one thing that I can contribute to this discussion, and please forgive me, if you think it's too base or too not very informative of me. I think, in Pakistan, in the rural areas, specifically in the rural areas of Sindh and Balochistan, of course, the intervention on the basis of, educating the recipients, if I may, for instance, the recipients of care on different levels in primary care, in secondary and tertiary care. But I think, the other side of the table, which is the caregiver, that is also an important, component of this debate. I know for sure that there are people, basically who are giving care on different levels, who have different issues, with different, psychological issues, ranging from simple depression to bipolar disorder. So imagine if somebody is giving an important care to a patient and that person himself is not mentally fit, he or she has issues. So I think this one component can also be brought in this discussion. I'm sure it is already there, and I couldn't pick it, but still I thought that I would mention it. I want to take this opportunity to thank our friend Shakil Salam for being a linchpin for me, in this region, because this is not the only time that I'm basically being part of a debate on this or similar topics. What I've done is, in Greater Manchester, I've tried to rope in groups of people, mainly our women folk, to come together and try to discuss these issues. Because everything emanates from the mind. If you are mentally capable and mentally fit, then the rest of the stuff just follows. So thank you, Shakil Salam, brother. And once again, amazing time spent. I wouldn't think twice before, being part of this once again. Professor Nusrat Hussain, thank you again, and have a good day, everybody. Thank you very much.
Thank you, Tariq Saab, for all your support. Also bringing up about the possibility of Jinnah clinical lecturerships. We would like to take that forward, who can focus on inequalities. I would like to, thank Maria for chairing this session today. I would also like to thank all my wonderful colleagues who kindly have supported and have given their presentations today. Many of them, because of short time, have not been able to be present here, but have contributed to the work which, particularly Imran, Naseem, and others have presented about the work in Pakistan. We would like to thank our university. Without the support from the School of Health Sciences and all the colleagues, it would not have been possible over the years to be able to do that. And also colleagues from outside the university, both in the UK and abroad. We are also thankful to what Naseem has shown about the commitment of the Parliament to the research and our Prime Minister and the President. But the important bit is about that research is too important to be left to the academics. And there has been excellent support from family, friends, colleagues who are in the social media, without whom it would not have been possible. I'd also finally would want to thank people here who have joined the meeting today, and there are a number of people who may be watching on the Facebook. So thank you very much all. There are a number of projects which are going to develop from here. Feel free to send us emails and we would respond. It would not have been, again, it went very, very well. It could not have been possible without Dilip and Bilal to make it happen. And thank you very much all. Bye-bye and Khudafez.
Thank you.
Allah Hafiz.
Allah Hafiz. Allah Hafiz.